Welcome to the Veterinary Rehabilitation Podcast, where we aim to help fellow veterinary rehab therapists increase their knowledge and elevate their practice. I'm Megan Kelly.
And I'm Ané Lloyd. Together, we bring you the latest insights, research, and information in the field of veterinary rehabilitation.
This podcast is brought to you by Onlinepethealth, a leading continuing education membership for veterinary rehabilitation therapists. With Onlinepethealth, you'll have access to a wide range of online resources to help you stay up to date with the latest techniques, advances, and trends in the industry.
Our podcast features in-depth conversations with leading experts in veterinary rehabilitation. They share their own experiences and knowledge to help you improve your practice. Whether you're a seasoned pro or just starting out in the field, our goal is to provide you with the tools and the insights you need to succeed.
So join us as we explore the exciting world of veterinary rehabilitation and help you take your practice to the next level.
Hey Vet Rehabbers, in this episode, Ané sits down with Hero Braces Ben Blecha for a deep dive into Achilles tendinopathies and the important role that bracing can play in the recovery process. Ben breaks down the mechanics behind an Achilles brace, so how the lever arms and forces are applied, and also what keeps the brace secure without slipping down the hock, and why these details actually really matter for successful healing. They also explore the function of the foot piece and how Hero Braces use a clever articulation system to gradually increase the range of motion over time. Now this month, it's our birthday month, and we're celebrating with our friends from the Masterson Method to share 2 free webinars with you. The first one is Gilding Scars, the Masterson Method Perspective, and this is by Jim Masterson and Vanessa Hildy. And the next one is When Less is More, the Masterson Method in Canine Rehabilitation, and that's by Dr. Robin Robinette and Jim Masterson. So you can access these for free. You can head over to onlinepethealth.com/gift. These are our birthday bonuses for the month of February. A quick word from our sponsors before we dive into today's topic. At Paw Prosper, we believe true pet well-being demands a 3-pronged approach: prevention, support, and rehabilitation. Our brands are trusted by veterinarians, universities, and rehab facilities alike. So whether you're looking to train, rehabilitate, or help your patients age gracefully, our brands, Walking Pets, Help 'em Up, Respond Animal Therapeutics, Fit Paws, Muffins, Halos, Sleepy Pod, and Canine Carts offer effective, innovative, and proven solutions. You can sign up today to receive a one-time special gift for all our Online Pet Health listeners with your next order, and you can go to pawprosper.com/OPH. All right, over to Ané and Ben.
Hi guys, and welcome. Hi Ben, thank you for joining me.
Hey, thanks for having me.
Awesome. Guys, so we are live today with Ben Blecha from Hero Braces. It's been a long time since Ben's been live with us, so this is really exciting. I'm very excited to chat about our topic today, which is Achilles tendon injuries and bracing's role in that rehabilitation process. So I think Achilles tendon injuries are one of the trickier presentations, the trickier conditions that we have to deal with. I certainly don't like working with them. So I think this is a really great topic for us to dive into. All right, Ben, can you please introduce yourself? Let us know a little bit about yourself and the story behind Hero Braces and
Well, sure. Well, my professional training is in human prosthetics and orthotics. And that's where I cut my teeth, I guess. And well, it's 20 years ago now. Actually, last month, I met Carrie Adrian and Dr. Taylor out at Alameda East, and started working with them on braces. And it's just over the years, it's slowly morphed in. I ran that through my private practice then on the human side, and then started Ace Ortho Solutions. I don't know if anybody remembers that brand. And then my uncle is a veterinarian. He invested, and then we switched to Hero Braces. The reason is everybody was starting to confuse us with Ace bandages, and they were Googling the wrong thing. So we had a branding agency change it. So, and yeah, it's continued to grow, and now we've combined with some other great bracing companies, Wiggleless and Dog Legs and Medipaws, a boot. And so we have almost a complete line of bracing options, and from soft braces to custom braces and coverage products for cone alternatives. So covering the wound instead of instead of just protecting it that way. So.
Oh, I love that. That's a really comprehensive scope, right? From all the different bracing levels, really. I love that. Thank you. Okay, so before we really get into the bracing components of Achilles injuries, I want to just take like a few minutes to lay the foundation of Achilles tendons and the injuries and where we are on that front so that we're all on the same page. So we actually have 3 webinars in our Online Pet Health membership that are fantastic on this subject. So if you guys want to dive deep into Achilles tendons and rehabilitating them, the surgical options, etc., I recommend those. One of them is with Patrice Mish, and she goes into the use of dynamic orthosis in the surgical and non-surgical treatment of the Achilles mechanism. So brilliant webinar. And then distal extremity injuries, sprain or worse of the Achilles complex with David Dykes. Again, just that one is my go-to. That's the first one I go watch when I need to check in on my knowledge on the Achilles. So if we think about the anatomy of the Achilles or the common calcaneal tendon, it's made up of the tendons of 5 muscles. The gastrocnemius is the primary, the biggest one. That provides the largest contribution to the tendon, and its medial and lateral heads anchor the tendon to the calcaneus, and it surrounds the superficial digital flexor muscle and tendon, which then lies inside and underneath the gastrocnemius. So the superficial digital flexor tendon is the next contribution. And then biceps femoris has a slip, a tendinous slip that attaches onto the calcaneus, semitendinosus, and gracilis. So those are our muscles. And then when it comes to injury of the Achilles tendon, we can have an acute traumatic injury, which is usually like blunt force trauma. It's pretty straightforward. Usually those will come in acutely because the dog will be fine, and then they'll hit the Achilles against a door or a car or a sharp ledge, something like that, and they will be acutely non-weight bearing. So generally those come in early. And surgical intervention is usually the go-to for that acute traumatic injury. And then there's an atraumatic rupture, which is more tricky because it's a degenerative process. So there can be quite a bit of fibrosis and damage that's happening in that tendon. And it's usually closer to the insertion, where the traumatic injury is generally more in the middle of the tendon body. And where it is really important. So where that injury occurs on the tendon is important because of the vascular supply, right? So if we remember, the tendon is surrounded by a sheath, and that sheath actually prevents direct access of the vascular system to that area. So the tendon's receiving its nutrients and its vascular supply either from the osteotendinous junction, so the closer it is to that calcaneus, the more blood supply it will have, or from the musculotendinous junction. So again, the closer it is to the musculotendinous junction, the more blood supply it will have. So Ben, what are our options for bracing, right? And how does that differ between, let's look at post-surgical first, because I think most of the time we're going to have a surgical fixation or surgical correction, and then that's going to be supported with bracing. So what does that look like? What should we look for in good braces? Tell us a bit more.
Yeah, so surgical intervention is, historically, most surgeons, what they want to do is cast the leg at 165 or more, and have the toes fully out, and I guess coming from the outside of the industry, I've felt like that was a little bit too conservative, but that's pretty much what literature has said, and so most surgeons, that's what you're going to see. And so bracing is still relatively new to what surgeons, how they want to intervene with it. So there's little pockets of strong rehabbers that have talked their surgeon into doing bracing post. And so generally most of those surgeons, they want to okay, well, you can use a brace like a cast. So I want it 165 degrees. And at least from a manufacturing standpoint, it starts to get kind of complicated. So early on, I mentioned 20 years ago when we first started trying to address this, we tried to start using human components to be able to help this. And so there was these elbow joints for humans, and they had variable range of motion. So there's like 2 set screws on it, so you could set what range of motion that you wanted. The problem was that you had to fit it on a larger dog. You couldn't fit them on the smaller dogs because they were, even for a human elbow, that's quite large for a 20-pound dog or something. So one, we could only do it on the larger dogs. And what happened when you had the larger dogs, they would basically, the joint was made out of aluminum. And if you didn't have that joint exactly square to each other and have a axis alignment exact, if it was off a little bit, that would bind up in the metal, and it would just tear that metal up. Or you couldn't really get free motion in it. And so in theory, it was great because people said, well, we can have different ranges of motion as we need through therapy, but in clinical practice, it didn't really work. There's a company, I don't know if you remember years ago, Vet Exos, that came out with an off-the-shelf version of a tarsal brace that was an upgrade to that. And it was smaller. You couldn't go quite down to a 20-pound dog, but we still had the alignment issue. So they brought in Derek Campana. He was with Animal Ortho Care then at that time, and he made these self-adjusting joints, which was a big step up. But again, we're just stuck with the larger dogs and doing that. So what happened around 2010, and we were all orthopeds was trying to do stuff. We were trying to do stuff. I think around 2010, I remember Patsy Mish speaking at NAVC, and I think she did a couple other conferences talking about their I don't think they call it a graduated. We've been calling it a graduated, but it's adjustable throughout the process. And so what they did is they used more of the geometry of the plastic, and they had some Dacron straps that you could take screws out and change the range of motion to be able to get through that. And then we kind of in parallel were creating what we call a graduated brace. And so it basically has a joint, but it comes as, it's not cut, it's solid here to start with. And if you see this plastic thicker right here, what happens is you start in a solid state. This isn't 165, but basically they wanted at that straight 165 and keep it solid. And they were basically just mirroring what their casting protocol was. Okay. And so then at some point you took a Dremel or your cast saw and you completed this cut across here, and then it became articulated so you could extend, but because this plastic was in here, you couldn't flex. Okay. So then it stopped from that hard pressure pulling on the Achilles, but it still allowed the Achilles to contract some, and you could try to push off a little bit. And then what you do is you just take little wedges out, and so that allows more range of motion as you go down. So each company has come up with some sort of version of this graduated style. And at least initially when you're working with a surgeon, they wanted it 165. Like I said, I've kind of pushed the boundaries on that, and that's more on some conservative side, some stuff that we've done with Carrie Adrian out in Colorado now. And those were like 2C categorized, so they weren't complete tears like the surgeons would do with the surgery.
Okay, great. So that graduated brace, particularly for an Achilles injury rehabilitation, is important because we need to progressively load the tendon, and that means it needs to be able to take just a little bit more range of motion during the healing phases. I really like that solution that you've come up with of where it's a hard stop, essentially the plastic on the front is going to prevent the flexion. I like that. That's clever. How user friendly is that for the owner? Do they need to bring it in every time to adjust that?
Yeah, I mean, I think if you're going through proper rehab, they should be coming in, once or twice a week anyway. And so that just becomes like on week X, then you're going to cut that more. The user experience with the owner, and it's with all the braces, the tarsal braces are tough to keep the paw and everything in, because you also have that contracture that's happening from the superficial digital, and that's one that wants to contract, and so what that does in that contraction, it kind of pulls it up, and so it's always counterintuitive to the owners. They think that putting the brace on a little bit looser makes it more comfortable for the dog. But what that does is it lets it slop around inside the brace, and it doesn't let the brace do what it's supposed to. So when they start doing that, you start getting more contracture because you're not actually holding it in place. It's sliding up and down, and it's rubbing sore somewhere. So that proper training of putting that on early on is important. That's more the tough part with the owner, because if it gets too loose, then it causes wounds in weird places that they can't tie the what and why to why it's causing a sore in that spot.
So can you talk to us a little bit about that foot portion of the Achilles brace? Why is that important? Do you always need it, or is that just in certain presentations?
Yeah, I mean, I guess on some of the smaller dogs, it's could be okay. There's always this internal struggle for anybody that's using a brace. They want it to look normal or have this range of motion at this joint, and there ultimately there has to be some give and take. But if we the biggest thing that people complain about having the paw section is adding the height. So if you add that height, then you're tipping the dog, and then you start having spinal issues and things like that. Well, that's true, but look, if we go back and look how the dogs have been treated with this for the last 100 years, and this casting in a straight line, I mean, that adds a couple inches to the length of the dog, and they're swinging it, circumducting, and so if we have this brace on it and we have the paw section, we're not adding more length than what we've done historically. So let's start from that grounding. Now we still want to reach over to a spot where we're closer, right? And so what I would suggest, if it's a unilateral issue, then put a little booty on the other side, and then you've just offset the height, and so that's one way to approach it. Generally, I haven't even worried about it, but the thing about it, and to me, the trade-off is it's really important that it's a part of the brace for a couple different reasons. So the first reason just has to do with the biomechanics of the brace. Okay, so if we have a hock here and the Achilles is injured, what happens? The dog wants to flex, right? And we go into this drop hock position or whatever. So in order to lift that up, we need to be able to push here on the front of the tibia. Okay. So in the other spot you're going to push is somewhere back behind. I mean, you can't really push here because you have an injury. So you kind of have to push here and kind of lift against gravity. Okay. So you have a lift spot here. And then if you look at a 3.4 system, so if you're pushing here and here, you need to push back here somewhere. So if you don't have the paw section on here, you're relying on that strap to do that. Well, most generally that strap's going to come somewhere across here. Okay. So if you measure the center of that strap from the axis, this is the length of your lever arm. Okay. So and then you'd have, you're really trying to push up here. So you have a longer lever arm. Now, a longer lever arm means, so if you're pushing here compared to here, you have to push twice as much force here as you do here to get the same amount of outcome. Okay. So the skin can only take so much. And if you're trying to push here to limit this motion at this joint, you have a higher chance of having skin breakdown. So that's why we want to bring our lever arm as high up as we can without going up over the stifle, right? Mm-hmm. Well, the same is down here. So if you take the pause section out, you've basically created your lever arm so it's half as long as what it could be. So you're adding a lot more force into what has to control that joint. So just by bringing the brace down here, you're extending the lever arm of what's going on, okay? And reducing the forces that you have to control this joint. So that's the first thing. But then the second thing also ties in with it, because where you get this force down here, because you don't have a strap at the paw, is a ground reaction force. So ground reaction force is pushing up here, and then you have an equal and opposite force pushing back. So that's your third force. So it brings your force from here all the way down to matching up where your ground reaction force is. So you doubled or maybe more your lever arm so you can control that joint better. So that's the biggest reason why. It is just the leverage, so you can reduce skin breakdown and actually control that joint in a good way. The other part is, if you only bring the brace up to here above the paw, you can use these straps, but to keep the brace suspended in place, you really have to start using some of the geometry of the leg too. But what happens is, because this is relatively the same radius all the way down in this segment of the body, it just wants to slide down. So if you look here from the side, see how the contours go? And if this slides down, well, what the plastic's cupping around, well, what happens is it falls down into that. And then, it's shifting up and down, and that's causing sores. So by actually having the paw section, when that hits the ground, it makes sure that everything stays in place, because you have that force holding it up and suspending it. So those are the main reasons why I like to include the paw section. You can get away with it in some of the smaller breeds. But it kind of depends on the geometry of how well you can hold that on, especially if you're trying to hold it 165. It's basically just a cylinder that it can slide down, and so when you're holding the hock in a more flex position, it's a little bit easier to hold it and suspend it that way.
Okay, does that paw section stay on throughout the rehabilitation process and from beginning to end, or do we use it in the beginning and then it's one of the things that we remove closer to the end of rehabilitation?
I think the orthoped style has a joint so you can remove it easily. You technically can on ours and cut it off and kind of bevel the edge. I just feel like once you're to that point, you're probably the point in where you're only wearing the brace during high activity times, and you're already kind of starting to wean out of it in a way. And it just, to me, it's kind of pointless to send it back and forth between a manufacturer to have some sort of changes. Just kind of stick with what you're doing, and because if you cut it off, then you're changing the whole dynamic of the fitting. You might run into a whole bunch of fitting issues that have a back and forth and whatnot. And if you've already worked through that in the early part, why would you introduce that and complicate the process later?
Okay, perfect. Thank you for explaining that.
Yeah.
That was really good. I'm not very familiar with bracing. It's never been something that I've closely worked with. So hearing you explain about the forces and thinking about the lever arms, and it reminds me why we have to take physics.
Yeah, we just went a little bit though, right?
Yeah. But I also remembered that that's one of the things that Patrice Misch goes into quite a lot of depth in her webinar. She did a 4-part webinar series for us on orthotics and bracing, and so she explained that concept really well, which I forgot about and remembered when you spoke about it. So now you guys know.
Yeah. Well, she does a great job.
If you want to go really into that, because it's very interesting and I wouldn't have known. So yeah. Okay, so that graduation of the brace is going to allow us to increase the forces that we place on the Achilles tendon, and the amount of muscle activation that we get as we go through the rehabilitation and progressive loading of the tendon. How long does that usually take? What is the timeline that we're usually working with for a post-op Achilles injury?
Yeah, I mean, and that one's so tough. There's so many other factors on how well the Achilles could possibly heal. And so one, you can just start with age, right? A puppy is we just had a puppy that broke its leg and it healed its leg in 3 weeks, where it'd take other, 6 to 8 weeks, right? And so that's one thing that fits into it. Diet, comorbidities, how there's the list of comorbidities, diabetes, like you can just go down this list of things that compromise healing. And then there's also, what tools do you have at your disposal that help with healing? And I'm not in the doctor realm, but let's just start listing off a few that help with soft tissue healing, PMF, shockwave, laser, there's all sorts of different things that some people have access to and others don't, and what's going on. And then, Carrie and Dr. Green and Dr. Wright, they were doing PRP injections with it as well. So there's such a wide, in a way, it's such the wild, wild west of how everybody's treating it, and that's why I really appreciate when Patsy kind of started a protocol that we could start building from years ago with orthopeds. And Dr. Brummett we have one on our blog as well for our design. And so I think you start there, and then, but with anything, you just kind of have to understand the concepts of that. And, but generally in a good case, 12 weeks, but 12 months isn't unheard of. Right. So that's a wide range.
Yeah. Okay. No, that's perfect. Really, we're looking at tendon healing, which is ridiculously variable. It depends on the individual case, the surgical procedure, all the other things that all the other treatment approaches that have been brought in, and the individual patient's response to progressive loading and to the treatment modalities. So, okay, that's perfect. Do you work with conservative management of Achilles injuries as well in terms of bracing? Is that viable? Like I say, this isn't actually something that I'm super comfortable with, Achilles tendon injuries, because I think they're very tricky. But in terms of conservative management, have you worked with those with bracing, and is it positive?
So let's just start with the definition of conservative management. So that, to me, that's a broad word. So some people, it just means that it's not surgery, and some people mean it's crate rest. What were we talking about conservative management?
So for me, I'm talking about it hasn't been surgically repaired. A surgeon didn't go and reconnect the tendon pieces together. Which probably means that it isn't a full rupture. It would generally be only a partial rupture. And then you're waiting for that fibrosis to form, or scar tissue to form, or whatever healing you can possibly have. But usually it would be a partial rupture, and then it would be just that they did not surgically suture it back together. That is my definition of conservative.
Okay. So that means that we can throw in any other modalities to help.
Basically everything else. Yeah.
All right. Okay. So, and that kind of leads into the, we've had people come to us that have just tried to do this and not do anything else. They couldn't afford surgery, and there's varying outcomes with it. We've tried to take a more research-based approach. Carrie was really trying to do this. She had, I think it was 3 dogs, and I want to say 1 cat, but don't quote me on the cat because I don't remember the specifics much on that one. But we had 3 dogs that I think there were 2 C's for the rupture, and they did a their PRP injection protocol. And I have the roughed out paper here, but I don't know what the protocol completely was. Hopefully she has this paper out soon. And then so everybody can see that. But so there's 3 dogs, and just the quick results was 2 of them returned to hunting, and the 3rd returned to be a family pet, but they put the precautions not to go do the 3-mile runs or whatever where the spouse went and did that. So that there was good outcomes with that. And what they did is we did the bracing protocol with PRP, with their PRP protocol. And then we ultrasound at different segments. I think we even might have gone at least a year, but maybe even 2 years out in the ultrasounds. One of the funny parts, maybe not funny. We always kind of question what we're doing when it's so new in a way. As Dr. Wright, when she was ultrasounding early on, she's like, this doesn't feel like this is healing, and then so we all like, how long do we, do we wait till we see the whites of their eyes before we stop this, and when do you stop? But we followed through with it. And then I just remember getting a message how pleased she was at that 2-year mark. Like, oh wow, this did some good, and so I think that was a big relief to everybody. Now I don't know what it compares to the surgical outcomes with that. I'd have to punt to Carrie on that, and Dr. Wright I'm not the doctor, so I don't read the ultrasounds, right? But one of the interesting things with this is, Dr. Green was a surgeon and involved with this, and everybody leaned toward that 165. But when we went back and looked, and the braces were built at 135 degrees, 140 degrees, and 150 degrees. So at best 15 degrees shy of that. And it was a little bit of an accident, I'll be honest. It was something that I'd always pushed the boundaries with, and the lab knew that. And they actually built it to those degrees that they were seeing in standing pictures. And generally what we do is we add 10 to 15 degrees to the standing angle of the sound side. And they didn't realize that these were study ones that they wanted at 165. So we messed up on that, on matching what they wanted, but they were following our protocol with it. And it was an accident. I wasn't trying to sneak it in, so somebody could test my theory. But the thing about it is we're still getting some good outcomes. Like, obviously there's still one that wasn't perfect yet. So I'm never, and you'll hear from me all the time, I've never seen anything perfect, surgery or anything, but it gave some food for thought on how conservative do we have to be on this angle and holding it. And part of my feeling was that we need to still lift up enough to keep the pressure off the tendon. And I'm 1,000%, but we also have to have some slight pressure on it to activate the body's response to healing it. Right. And I understand also surgically it's completely torn. So these are impartial tears. So, but I want to do it in a controlled environment. And so we have a couple different things that are going on. If we don't keep that superficial digital tendon moving some, it adheres inside it as we're trying to fibrose it. And then our contractures become a nightmare even later when we're trying to work on rehab last. So I want to keep just a small amount of motion in that tendon going inside that, so that doesn't adhere. And so like, I really like doing that inside the brace, and we can do that with the paw section. Patsy and Martin early on, what they were doing, and I think they still do, they put a pad in the back to kind of lift the heel up in the heel section. And then you take that out in stages so you can allow that in. I like to keep the void in there. So there's a spot for that paw just to kind of move inside of it. Going back to, people wanted the motion at the paw. That's why they want to remove the paw section. But if you keep that void in the bottom, that paw can slightly move inside of it and keep that tendon just slightly moving so it doesn't adhere while everything's trying to fibrose up here. And that's and ultimately you can't stretch that contracture out if you're holding it in a contracted position and you have it lifted. So that's why I like to do it that way. I don't know. I think I just went on a tangent, but so what we're doing with that is, what I like to do is I like to look at breed specific standing angle. I don't like 135 as this average of all these different breeds and all these different dogs. But if you look at a shepherd, the shepherd has a much more crouched gait, right? And it's just natural that way. And so if you try to hold them up at 165, there's no way that they're going to walk any normal way in the rest of their body. So what I like to do is say they're at 110, hold them at 125 or 130. I mean, not quite the same math. I'd say 10 to 15 degrees. I might be a little bit more aggressive on a shepherd, but they're a powerful dog too, right? And so I just want to hold it at a little bit more, and then let the PRP help with the new soft tissue formation that we need. And then as you do, you go to that graduation. There's a lot of people that want like 12 steps in the graduation. I think you can just simplify it. You start solid, then you have it so with a plantar flexion with a stop, and then you add 15 degrees, and then you slowly graduate them out, and they're only using it at high activity times. So that's our general protocol that we're doing it. And the study's showing that we're getting some good long-term results with it. So yes, I think you can do it conservatively. And I think if you start throwing more modalities to help with that soft tissue healing, I think you could even accelerate it and have better outcomes. But we'll always take on more studies, and we'll make braces for people that want to do more studies on it. So
yay! So guys, invitation. If you want to do a study involving braces, talk to Ben. Okay. Yeah. So did you say there's 3? You essentially work with 3 graduations of the brace.
Yeah, 4.
4.
Well, there'd be 3. You start with the solid, and then there'd be 3 graduations from that. So solid to articulated with a stop. Then you add 15 degrees of flexion. So you make a little cut in the stop. And then is the wean out. So around the house, you're not wearing it, but at high activity times you are. And then to where you're done. So
one of the trickiest things, and you actually touched on that earlier, is actually the working together between the veterinarian and the rehabilitation therapist and actually the owner, which I sometimes forget about the owner, but they're the most important component actually in the whole team.
If we can get them to fall through, yeah.
Do you have any advice for how we can, for that specifically with these cases, how we can work with the veterinarians to get them on board if they're not using braces already? How do we work with them to introduce braces? And if they are open to that, what are some tips that you have for that relationship specifically with these cases?
Yeah, I mean, so with the veterinarians that we're talking about right now, so start with what they know. The best part with, start with this, they know we're going to do 165. So if you're going to introduce bracing, start there and then plant the seeds. Like, hey, these people are doing with less range of motion, you know, like, but don't try to bring it close to what they know first, right? And then slowly take the steps to where you want to be. I think so many times what we try to do is we try to go into a surgeon and say, hey, this is where I want to go. And it's so far from their best practices. It's such a large leap that the easiest thing for them to say is no. Right. And so like, if you want to collaborate, you have to start with where they're at and then move to where you want to be and where we're finding best practices to be. So.
Okay. I think it makes so much sense to use a brace with an Achilles tendon because it allows you to still do potentially some passive range of motion in the toes, in the stifle, in the hock as well, which allows you to control, like you said, contractures from forming, which can be a major complication. And gradual loading when it comes to tendon healing is by far one of the most effective ways for us to stimulate healthy healing and to speed up the healing process. If we can't gradually load that tendon, if you're sitting for 12 weeks in a brace, in a cast, and then removing it and then loading the tendon, the risk of re-injury is so much greater than if we were able to build in gradual loading over time. I think that is for me one of the biggest things with this condition is that bracing just makes so much sense because we need that progressive loading to have a good outcome. So that would be my kind of focus.
No, and I agree. And so, like, I mean, I'm an amputee. I had cancer when I was 16, and I remember coming out of my first knee replacement surgery in 1991, and I was at a pretty prestigious college, and they took me out for physical therapy the day after my surgery, but they told me like 5 years before I would have been in a cast for 6 or 12 weeks and my leg would have been atrophied, you know. So those were things that we learned, I mean, back in the 70s, 80s, 90s, right? And we'd like to think that that's where we're trying. And you know, some of us that have been in the field for so long is like, just listen to me, this works, right? And I get the frustration, but just take this case. So like stifle surgeries, like they knock those out every day, right? But Achilles ruptures, they're a nightmare. And they're a surgical nightmare too, right? And so the best thing that they do is go ultra conservative on this and hold it. And so that's where like that's their safe area, right?
Yeah.
And so that's why I'm saying, like, yes, this is where we want them to be, and we have to plant those seeds along the way, but give them something close to it. Like talk about how a brace and a cast are similar. You know, this is solid and this is solid, but I can remove it and I can do slow passive range of motion, you know? So I'm getting, you know, in a controlled environment. So then they're like, oh, okay. So the shepherd's not going to go jump over a wall and, you know, and so you're kind of meeting them where they're at. And then as they get to be more secure with that, then you can start changing the range of motion quicker and those things. And so that's, I guess that's where I'm going. Like we have to look at both extremes of what we want, and we can't take a quantum leap. We have to take incremental steps to it. So
I love that. Thank you, Ben. So Ben, where can people learn more from you and more about Hero Braces and more about the other products that you have that allow a wider range of support?
Sure. Well, so our Hero Brace blog, we're trying to add more and more information on bracing and the nuances of stuff. So that would be a good place. It's blog.goherogo.com. And then just for like our for veterinary professionals, we have special pricing that for all of those different companies that I talked about before at medivetproducts.com. So we don't want owners to go to that one. That's just for veterinary professionals, where you set up an account and we get you the professional pricing there. So
thank you so much, Ben, for your time and for sharing your experience and your theories and your knowledge. I really appreciate it.
If you enjoyed this podcast, please hit the subscribe button so you get notified every time I load a new podcast. I'm here every week talking to vet rehab therapists from all over the world about all things vet rehab. A big thanks to our sponsor, Paul Prosper. Their sponsorship allows us to be able to give this podcast to you for free, so please go and check them out, paulprosper.com. Don't forget to bookmark the next Vet Rehab Summit. It's on Saturday, the 31st of October, 2026. Come and be a part of the world's largest online veterinary rehabilitation conference created specifically for you, the vet rehabber community. Online Pet Health members get VIP complimentary access to the Vet Rehab Summit. For more information about continuing education for vet rehabbers, you can go to onlinepethealth.com. And if you want access to our free membership, we update the webinars in this area every 3 months. You can sign up at onlinepethealth.com/free.